Greetings, everyone. Welcome to our little event here put on by the Center for Refugee and Disaster Response. And I have the great honor of introducing Dr. Paul Spiegel, who's going to be our speaker, discussing the crisis in Syria. And I want to give a little bit of background on Paul. I just found out that we have similar careers and that we both dropped out of training. And after we dropped out of training, we came to Hopkins, and he actually got his MPH degree here at Hopkins. And so he, like a lot of you, is an epidemiologist trained at Johns Hopkins. Currently, he has the title of the Deputy Director of the Division of Program Support and Management at UNHCR. And he is an associate on our faculty here, as well as another other universities whose names we won't mention. He worked at the CDC for a long period of time in their refugee section, and prior to that worked for MSF in the field in different camp settings. He has a tremendous amount of experience, and he uniquely kind of brings science to an organization, UNHCR, that isn't famously known for science, and has been instrumental in bringing a kind of a new, more rigorous look at the way we intervene into humanitarian crises. And I think that this will be a good example of that. Paul?
Great. Good morning or afternoon, everyone. Let me put this somewhere. Put it here. Great. So thank you, and thanks colleagues for inviting me to speak. I just flew in yesterday, and so I'm here for a couple days before going back. I wanted to talk to you about Syria because of the huge importance of what's happening in Syria, and I'm sure most of you are aware, but the events that are happening in Syria, for many of us in the humanitarian crisis, we haven't seen anything like this for many years. The closest thing that we can think of, although completely different, was Rwanda in '94. But it's of that magnitude of the amount of people it's affecting. So I'll start, and then I'll try to do this within about 40 minutes or so, and then I'll open up for questions. And during that time, I have a small video. Let's see if this works. And I haven't used Prezis that often, so let's see what happens. I'm hoping I won't make you nauseous with the back and forth. Okay. So, firstly, UNHCR. I think most of you know about UNHCR. I won't go into detail except to say that it is a protection organization. It's a protection actually and solutions organization. It's not a health organization. Protection can be interpreted in the broad sense, which for us includes assistance, but it's to protect persons of concern, refugees, internally displaced persons, asylum seekers, stateless. The second part of the mandate is solutions, which is different from many other humanitarian organizations because it's meant that we start from an emergency and we end when there is a solution, of which there are generally three. Refugee returns home, a refugee, which is the best solution, voluntary repatriation. Secondly, a refugee may be locally integrated. And then thirdly, which happens, but it's a very small amount relative to refugees worldwide, they're resettled. And U.S. is one of the biggest countries. U.S., Canada, Australia are the countries that resettle most of refugees. Now, we've been changing a little bit the way we're thinking about refugee situations. And even this slide, does this work? Yeah. I would change the slide now and do it differently. The issue is, in the past, most refugee situations we were dealing in camp-like situations, primarily in sub-Saharan Africa. So much of the response and the way we think of responding to refugees is in sub-Saharan Africa in a camp. More and more, though, now, we would divide into, forget this part, we would divide into urban and rural. And then we would start looking at the settlements in urban settings and in rural settings. Generally, camps are in rural settings, but they can be in urban settings. But more and more, we're looking at non-camp settings and how to respond. And in non-camp settings, the response is quite different. Secondly, most of our experience has been in low income and low life expectancy. But more and more in the last while, we're dealing with middle-income countries, Balkans, the Iraq war, Iraq refugee crisis, and now the Syrian crisis. And how we respond, and we'll discuss this, but how we respond to these areas are quite different. This was something we wrote in the Lancet a while back, trying to look through and walk through some of these issues. But classically, actually we'll look in the middle income, you have a demographics of a population that is not dissimilar from here. Okay, you have a much older population than in Africa. You have a significant amount of non-communicable diseases, and it's difficult because we weren't necessarily in the humanitarian world. We haven't been dealing with NCDs sufficiently, and then we're dealing a lot more with tertiary care, and tertiary care is even more complicated because it's so expensive. And these are all areas that we, I'll walk through a little bit, but these are areas that we've really had to try to adjust in the last while, how we respond. And we've had to actually either make up a lot of issues or try to use our experiences in other settings and adapt them to the refugee setting. And at times it's been quite difficult. So this is the situation now, and here, obviously, Syria, and the majority of refugees are going into Lebanon, and in Lebanon we have a non-camp setting. There are no camps in Lebanon. There are informal settlements, but there are no massive camps. Following, you've got Jordan and you've got Turkey. These countries are taking the predominance of refugees. In Turkey, you have a mixture. You have the Turkish government, very strong government, very autonomous. They're running the camps in Turkey, primarily by the Turkish Red Crescent, and they are using a much higher quality than we can deal in other areas. It's very expensive, but the quality is quite high. However, they don't have the experience necessarily in some of the softer parts of running camps, of looking at camp maintenance, looking at the key areas of SGBV and how a community functions. Plus, there are many, many refugees outside of the camps, and access to those can be quite difficult. And then you have Jordan, and Jordan has been getting a lot of the attention, and we'll get to this in a second. But Jordan is, because they've got a lot of camps and some of the major camps there. But this is the situation. We have a website that's open. It's a Syria portal that's open to everyone. And as of last evening, these are how many people? 2.249 million refugees, of which UNHCR has registered 2.169. This means that these are waiting to be registered. And this portal actually gives you a lot of information about the age breakdown. You can then move by country, and it has all of our reports on there that are open access. Years ago, we didn't do anything like this. And some of the things I'm going to be showing you now, we've really changed, I think, in the way we do our business, not just we, UNHCR, but everyone, trying to be much more communication savvy. And that's really important in this day and age as things are moving. And in the past, we never had a portal like this. This is just looking at, this is the most expensive appeal ever launched by the humanitarian community. This is for 2013, and we've appealed for not just UNHCR, but this is the Refugee Response Plan. So it's a mixture of well over 200 agencies, UN, government, as well as international national agencies. This is what has been appealed for. The coverage is 62%. So out of this appeal, we as the community has received approximately 62%. It's a massive amount of money, but it's still not close to enough. And in the next couple months, we will come out with what's called the RRP6, the Refugee Response Plan 6. And that's going to be over $3 billion. And that will also come out at the same time in a combined appeal with what's called the SHARP, but the Syrian Humanitarian Response Plan. What's unique here is, of course, the numbers of people, but also being in a middle-income country, the costs that are required here, winterization, shelter, is just a massive amount of money. And it's also very clear that the humanitarian community and the donors will not be able to support this as we've been doing. I mean, it's well beyond a humanitarian crisis at this point. It's much more now, for Lebanon it may be existential, but there's a whole development component that we still have not sufficiently linked up. And we'll talk to you a little bit more about this. So this is Zaatari. This is the camp that I think that's gotten the most amount of publicity, for good or for bad. It's an astonishing camp, and I want to play you, if I can, if this error will work, is we have, again now, we've never had this in the past, but now we have a bunch of YouTube clips, and this is we have a series called A Day in the Life of Zaatari. Uh-oh. This always happens, doesn't it? Let's see. Oh, I saw it. Any thoughts from my colleagues back there? Okay, I may do one thing, because I want you to see this. It's quite interesting. I may be able to just do this. If I put my glasses on, I'm just going to do a quick search of a day in the life of Zaatari on YouTube. Don't you hate that when this happens? Okay, Zaatari Camp. Okay, no, this should work, no? Okay, let's do episode 1. See if this works.
Set up a functioning community. We did it in months. It is now coming to real life.
When you talk about 500,000, most of them have relatives here.
Yeah.
Or neighbors or whatever.
And are her relatives in Zaatari, or are they in Erbil, or where? What made you come across?
ليش جيتي ستي هالأيام؟ ليش ما جيتي قبل؟ شو اللي خلاك تجي الوقت هالأيام هاي؟
صاروا يضربوا علينا على المدينة.
Okay. And you know you may be going to Zaatari Camp?
تعرف إنك راح تروح على الزعتري على المخيم؟ Yes, I know.
And that's okay? Who would travel for up to 2 weeks through the desert with their kids to live in a refugee camp if there was any other choice? Zaatari's got 120,000 people in it. It's now the world's second largest refugee camp. It's a city. And these people will make the city even bigger tonight. My name's Andrew Harper. I'm head of UNHCR's refugee response in Jordan. Walk across the desert, and sometimes they get lost. So they spend the first night here, second night here, come down here, third night here, then they go to Zaatari, which is here.
No, it's okay. It's okay. No, tell me. We have the operations room going as soon as possible. My name is Kilian Kleinschmidt. I'm the manager of Zaatari Camp. They call me the mayor of Zaatari, but I'm also simply the boss.
So I welcome you to Zaatari town. 120,000 people in 530 hectares. They came in last year, July 29th, 2012, settling down here in what has become today the old town in the west part, the downtown, the slum. This is where everything is happening. It's about 8.3 kilometers all around, and we have a ring road. We have other asphalted road in the middle. 3.5 kilometers from west to east. It's a big place. But it's not anymore a little refugee camp in the middle of the desert. It has become a city. Like everywhere in the world, these refugees were very angry people because they lost their homes, they lost family members. There's a lot of suffering in the conflict in Syria. But also there are people with an incredible initiative, with an incredible capacity to change the environment.
They don't like the way of how we put them down. They don't like the way of how we put them in rows, so they put them in little compounds.
They're traders. They're people who have all their lives in their history have been doing trading. So it's very natural that they set up shops. It's very, very logical for them that anything they touch, they transform into business.
So how much does it cost?
قديش what?
A cup.
قديش بدي على
Cup.
العصير؟
Yeah.
25 cents.
Okay. When we come back, I'll grab one.
نرجع نعمل.
Welcome everybody.
One dinar and how much? Like this? Like this? That's all? That's just cheaper than in Amman. Here we see a water tank being a private water tank. 8% of the camp inhabitants have a private water tank. Either they bought it or they stole it actually from communal facilities.
They have destroyed a lot. They have stolen a lot. Now, have they stolen it or have they privatized it? I think they've privatized it.
Wow. Okay, Kuwaiti, Oman. The real bathroom. What is that? Wow. It's the shower.
So they're saying, well, I don't want your communal toilet. I want my private one. So I'm taking the materials from your communal toilet and just moving it a few meters and I make it to a private toilet. So you will find everywhere the bits and pieces of the public toilets transformed into private bathrooms. And that's where we started building up the vision that there we're building a city. We said, well, we also will build a city. So we were trying to bring together our vision, their vision and our vision. So we're now converging it, we're bringing it to one. It becomes complicated.
I did not meet you yet. This is a beautiful example of how it should not be.
If we don't work together, who is going to do this?
Zaatari.
So, now let's see if I can get back to my presentation. Voila. Okay. Why I wanted to show you that was, it's funny because I've spent so much time there. I laugh when I see these guys. You have to be Killian and Andrew, the Australian guy. They're characters. But why it's so important is that unlike in other situations, you see this is a town, and everything we try to do, it shows you how you have to understand the culture. But these are often middle-income people coming into an area, and we set up the camp the best way we can do. Also financially, it's very, very expensive, but we set up things communally, and they ain't going to accept communal stuff. So they're just cutting up. We brought, as opposed to the camps, you see here the tents. Eventually, the Saudis donated thousands and thousands of containers. So these classic containers that you see, but these people use so much ingenuity, and they cut up the containers. They've made them completely different than we would ever have anticipated, and it's a wonderful thing. And you have different choices. And Killian, the German fellow there, has, despite his uniqueness, he's really allowed them to innovate and do what they can. I mean, they steal a tremendous amount. Everything we do, they basically just take, because rightly so, they want private. Who wants to have a communal toilet? So, but we couldn't afford to give everyone their own toilet. So to actually develop this, unlike in some other situations in the world, we've set up a camp, but we quickly realized it is a town. And we've brought in, actually, you wouldn't believe, but we have people from Stanford, people from the Dutch mayor's, Amsterdam mayor office, urban planners coming in to try to help us to understand the community better, to develop the camp the way they would like the camp to be, because it's not a camp, it's clearly a town. So, and you can go online if you'd like. It's the first time that we've been able to, UNHCR in the past, we never had anything like these sort of videos. Now we actually have a series, a life in Zaatari, and it's quite fascinating. So this is quickly, I want to just show you in Zaatari how we tried to get some of the health information system, and you can have a look at this. But the idea was that we have our online health information systems, but Zaatari was complex because at one point you had 4 field hospitals flowing in from the French, the Moroccans, the Saudis, and I've forgotten who else, all beside each other. And we had very little possibility of planning because it was all political. So the French, we wanted these field hospitals to be on the border to deal with some of the more complicated. They didn't want that. They wanted these field hospitals in the camps where they are. So to actually get the information was complex, and it took a while. But now we're getting, we've switched it to actually still may be weekly. It is weekly. We have weekly reports. This one is the latest on the web was the 26th of October to the 1st of November. But we're getting weekly reports. We get everyone to, there are numerous organizations there dealing with primary care, dealing with reproductive health care. Took us a couple months to get everything in order. They're now reporting, and we have a computerized system where we're able to get all of the information that we're showing you here, but also all of this is online so that not just ourselves, but everyone can see what the situation is in Zaatari Camp. And I will compare this shortly to out of camp. And in out of camp, we have completely different data. It's here we have a denominator. Here we're able to know there are only limited number of places where they can go to seek health care. We get that, and we're able to combine that into a report. You cannot do that, or it's extremely difficult to do this when people are dispersed throughout the whole country. And so that is a problem that we're working on, and we have some ideas of how to deal with that. This is the second for the same week, I believe. November 1st, where we're dealing with disease surveillance. So this is online as well, but we are able to quickly deal with, and you can see actually these are the weeks and the outbreaks due to watery diarrhea, bloody diarrhea, and we'll get to polio, which you've been hearing about probably, but there are luckily at this point no cases of polio. So these are some of the reports that we're using in the camps. We will be implementing these already. We're starting to in the Iraq camps. It is something that we're able to do not so easy because it requires a lot of different organizations to use similar formats to use certain case definitions. And you can imagine in a place like Zaatari, when you've got well over 40 different organizations, to get everyone to agree, not easy, but it's working, and we have a very good idea of the diseases and what's going on in the camps. Now let's look at Lebanon. In Lebanon, as I mentioned, we'll go there, but in Lebanon, I mentioned it's a completely out-of-camp situation. What we have found in many of these situations, and it was the same in Kosovo, it was the same with the Iraqi refugees, and it's the same here, is that if the refugees can cross the border, get out of Syria, cross the border, and don't die along the border due to war-related injuries, the mortality is not elevated in the camps or outside that we're aware of, at least, outside of the camps and inside of the camps in these countries. So the mortality, what we are finding, though, is that access to care is the biggest issue. But consistently now in Kosovo, the Iraqi refugees, and now in Syria, once they reach and once they get over the conflicts due to war, the mortality does not appear elevated, and the diseases are actually very, very similar to the surrounding host communities. And so the problem early on, we were trying to apply the same sort of logic that we need to follow, and we need to be able to look at the disease morbidity and mortality. More and more in the out-of-camp urban areas, what we're trying to look at actually is access and equity to services. That's number one. And number two is many of these people have sufficient means that the primary care, although very important, is not the big stumbling block. The big stumbling block, and that is going to kill people and ruin families, is the more expensive medications, and particularly the tertiary care, because we're dealing with many of these people, unlike in many parts of sub-Saharan Africa in the rural areas, many of these people come over, they're already on treatment for breast cancer, they're on renal dialysis. And it's very difficult to be able to have continuity of care. Plus, even if we can arrange the continuity of care, it is incredibly expensive. And this is what we can talk a little bit about here. So one of the biggest problems we've been having, I would say, is ensuring for non-communicable diseases the expensive care, particularly the diabetes, the expensive medications, and then even more difficult has been dealing with the tertiary care referrals that can cost tens of thousands, and we even had a couple in the past which we could not deal with that are over 100,000. There's a lot of thalassemia and other sort of rare diseases in this community. Now, this is old data. I was working on it last night, and I think we have newer data, but I couldn't find it. But I guess just to say here, for the most part, the nutrition status is also not the biggest issue. There's a lot of obesity amongst the adult population, but in the Africa situation, in many situations, it's the global acute and severe acute malnutrition rates that go up over time. This is not an issue amongst this population at this time. Of course, there are going to be cases of it, and we've seen these, but it is not a major issue compared to many other situations. The major issue is consistently, in fact, when we've done all of our discussions, the major issue for most of the refugees out of camp, number one priority is shelter. Shelter is incredibly expensive. Many are renting because it's after a while, when you have Lebanon now, nearly 25% of the Lebanese population are Syrian refugees now, and they are completely overwhelmed. Many people are renting, and so in fact we're doing a lot of cash assistance to refugees, and one of the biggest incentive that we're giving for cash is shelter. Let's see if this works. Okay, this now is to show you, and I'll go into this. You can't see it very well here, but I'll bring it up. This is now a study we did with a student, actually, who's doing her dissertation on this. This was in Lebanon, and working on the other big issue in healthcare is that they are completely different in Iraq, Lebanon, and Jordan. Particularly, Lebanon is a privatized healthcare system. Okay, it makes you Americans seem like you're a socialist system. I'm from Canada. So Lebanon is so privatized that it's extraordinary. And one of the things that we've done here now is we learned from the Iraqi refugee crisis. So we have anything over X amount, I think it's about $1,000, the organizations that we are working with cannot pay, and it has to go through what we call an exceptional care committee. This is for health, and we look at them, and then we try to find the money to decide on various issues. We have been collecting the data, and this is the data in Lebanon for our referrals. So if you look at the referrals, 36.5%, this is from January to June 2013, are obstetric care. And then what we started to do was compare the money to looking at how much we're paying, and we started looking at C-sections and what's going on. And this is 32% of all of the referrals were for the hospitalizations were for C-sections, and 56% for normal delivery. The C-section rate is way too high. And why is that? This is Lebanon. It's because we feel there are many reasons. Yes, they may be coming in too late for antenatal care. One of the main reasons is because it's a privatized system. You get paid a lot more for doing C-sections. You get paid a lot more for doing C-sections in the evenings after hours. So what we've done, and again, we've never had to do this before, is there's a private company in Lebanon that many Lebanese use. It's actually in the Middle East, and I've forgotten its name. And they pay this company, so any hospitalization, the company gets $50, and they have, with most of the hospitals or many of the hospitals in Lebanon, they have deals. So the company itself has to pay or agree, the company has to approve everything that is going on, and the hospital cannot undergo except for emergency treatment, but these are 24 hours a day. So we're just starting this, and we think we are going to save probably maybe over $1 million at least a year just on this. So it's a company that will deal with, it's almost like, I guess here, an HMO or something like that, is going to go over and ensure that proper care is given in Lebanon. Again, it's something we never thought of, but we were able to look at a bunch of different areas. We're able to look at where the hospitals are in Lebanon, who is charging what, and we're also, I don't know if I showed this. No, I didn't. We were able to look at per hospitalization what we're paying, and we are paying a tremendous amount of money for neonatal cases, which are a small percent, but they're using a huge amount of our budget. So what do we do there? Do we say we will have to pay less and let these neonates die? Perhaps. It's a decision that we're going to have to make in order to ensure basic public health principles that we help the most amount of people with the money we have. This is an older, but just to show you in Lebanon, the distribution of where the refugees are throughout the country, and this is even much worse now, but they are all over the country with, of course, some concentrations. So we're using these maps, and then we're also using the healthcare system, the education system, and trying to improve and buttress the existing systems. Many of you that know Lebanon, there's a caretaker government. It's very, very complicated country to work in. And it's not been easy to try to work at the municipal level. But the key issue here is, unlike in Zaatari, which is here, we are not trying to develop at all parallel services. We're trying to improve the existing services. And in Lebanon now, and you can read some of this, but this is some of the issues of camp versus non-camp. But more and more what's happening in Lebanon is that this is a refugee crisis that is having an effect on all of Lebanon. All the prices have gone up now in Lebanon. The schools are overwhelmed. They're having double, triple shifts. There aren't enough teachers for the host populations now because these countries have been, and I must say, these countries have been so generous compared to most other countries. They've accepted these refugees. They have, for the most part, not closed their borders. There have been intermittent border closures. But this is why I think this is so unique, this emergency is so unique, is the pressure that the refugees are putting on, particularly in Lebanon and Jordan, because they're small countries. Jordan has very limited amounts of water, and Lebanon has a huge, complicated ethnic mixture, of which now primarily Sunnis are coming in massive amounts. The unpredictability of this crisis is extraordinary. And so how to deal with camp versus non-camps, the positive and negatives were listed here, and it's been a huge challenge. So this is Zaatari, and these are the containers. As I was saying, they originally came in like this, but the refugees developed with their own welding, etc. They developed ways to move these containers, and they rightly so moved them to the way they wanted to. They cut up containers, they put them together, they made them much more friendly for their extended families, but issues that we didn't think of when we first received all of these containers. Okay, I think I only have about 5 more minutes, and then I wanted to hear from you. The other big area, and as you know, everything in public health and everything in the humanitarian world is politicized. So this came out November 8th. I don't know if this was big here and if it came out in the US, but and this is the things that we have to respond to. So Syria refugees could spread polio to Europe. You're probably aware that in Syria now, and the numbers have gone up, but I think there's a certain amount, at least 8, if not 30, cases of polio that have been confirmed cases of polio, primarily along the Iraqi border. There's still a dispute about how it came there, but one of the probabilities is that it came via, they've traced it to Pakistan. I think Pakistan or Nigeria, you'll forgive me, but one of the two where there are polio, and it likely relates to the fighting of insurgents coming in this area. So Syria, which had an okay, but not brilliant, but a pretty good socialized service previously, and they had a high vaccination rate against polio. The vaccination has gone down dramatically, the vaccination rates among Syrians. Furthermore, they're moving into in Iraq, and most of the majority of refugees in the Syrian crisis are outside of camps. In camps, it's a bit easier to be able to vaccinate everyone. Outside of camps, it's more complicated. And so we have to deal with this where suddenly Syria refugees could spread polio to Europe. And what's interesting is this came out of just a correspondence to The Lancet, I think the day before. And we have to think about how to respond to this, both from a public health point of view, but also a political point of view. Europe has opened up and agreed, I think, to resettle a limited amount, I think 10,000 refugees. It's nothing compared to the millions that have have left Syria, but on the other hand, it has a political effect by them accepting. So we have to be able to respond to this, which we tried to do in the next week or so in Lancet. And this is just what I want to point out to you here, is that we have an advantage because we work with the refugees. So we have been sending out test messages in Arabic to 125,000 registered refugees in Jordan and 79,000 in Lebanon, making announcements through satellite television, radio. So we are trying to do our best to be able to combat this. But the negative effects of this situation of refugees, and they're often talked about refugees spreading disease, when you have how many Nigerians and others are traveling the world, forget refugees, they're just traveling the world, Pakistanis traveling the world. You have economic migrants, you have people visiting their family in London. So we have to toe a line to say, yes, there is a big concern, and now WHO and UNICEF are making massive vaccination campaigns in the surrounding countries, together in Syria itself. And maybe, we looked at this and said, this outbreak could be a way to try to work with government and opposition to open up and allow us to do a bit more than has been allowed previously. And maybe the polio campaign will allow us to be able to do more humanitarian work cross-border and cross-line. We'll see. So we could see it as an opportunity, but we have to try to find a fine balance. And every disease outbreak that occurs has a strong political implication. So these came out after the Iraqi refugee situation, and we're using them now in the Syrian situation. We have principles and guidelines for referral health care, and these are applicable in any situation, but they are especially applicable in these middle-income countries where a tremendous amount of money is going towards refugees with tertiary care. And we have had some. It is very interesting because we also are a protection agency where we're dealing individually with many of these refugees. Despite these rules, we're often overruled by a representative who'll say, pay $30,000 or $40,000 for this refugee. I've seen them. We have to help their family. And if we want to try to use our money in a cost-effective way, we have to have rules that are very standard operating procedures that are known to the refugees. As I mentioned, we have these exceptional care committees where we have we have national doctors, we have clear rules of prognosis, cost, and then we make decisions because we can spend all of our money or much of our money on a very limited amount of refugees, and that is very bad practice. We're also working on how to access health care. This actually is, I think it's Iran. I'm looking at my colleagues there, and I have some colleagues from UNHCR Iran. But one of the biggest programs we've ever done is in Iran in the last 4 or 5 years, looking at health insurance, or 3 or 4 years. So at one point we had, how many, Arash? 200,000? How many people are Afghan? We had 300,000 Afghan refugees. We paid for some, and they paid for themselves as well. But we negotiated with the Iranian government to allow them to access health care. And so we had over 300,000 Afghan refugees. We still are having issues with it, but there are still over 200,000 now with health insurance. We are looking at this in Malaysia, and we are looking at this in Russia, and we have some smaller countries already that with health insurance. So we're trying to look at innovative ways that are allowing refugees to deal with accessing healthcare outside of the camps. Last slide. It was impossible to think about next steps, so I just wanted to give some examples. We are working on contingency planning. We, like everyone in the world, it's very hard to know what's going to happen in Syria. Is there, at one point there was going to be a strike, and how do we deal with that? We have to try to have contingency plans for a continued influx of refugees. We also have to expect at one point, if a massive influx, will certain governments close their borders? And then what do we do with that? There's a subtlety here, not so subtle, but of cross-border and cross-line operations. Cross-border are between countries. So along the border, as many of you are aware, many of the NGOs are working in Turkey into Syria. The UN officially cannot do that because officially Assad's government is still running Syria, and that if a UN agency does do that, besides having political issues, also it will have a big effect of how we act inside Syria. So we're towing a very cautious line there, and not always a very simple line. Similarly, there's cross-line operations, which the government has allowed us, and that is within Syria, but it depends. When we have to negotiate with the opposition and with the Syrian government to cross the lines to give, usually it's non-food items or medical supplies, it's very, very tenuous to be able to deal with this, and we hope the polio campaign will allow us to have better access. The last two are quite interesting, and basically they relate. We're trying to look now. What's been clear for a year is that this is well beyond a humanitarian crisis. We, as humanitarian people, cannot deal with this. The only way is clearly a political solution. But secondly, and what we've been trying to do over the last 6 to 8 months, is work with the development actors, work with the bank, with UNDP, with USAID, to try to get them to expedite the development, because we are working in refugee-dense areas, but there's a massive amount of infrastructure that needs to occur in Lebanon and Jordan in particular for the host populations and for the refugees that are adding a huge burden on there. So the World Bank is trying to expedite. We've done a bunch of joint missions with them, and they're trying to expedite certain funding ways of providing their funding. But it's complex. In Lebanon, it's complex because of the government. In Jordan, it's less complex because you have a very strong functioning government, but how to be able to get tens of millions, hundreds of millions of dollars from the development area and expedite it into the areas where the refugees are adding a huge burden on the national systems. It's really difficult. We're trying, and it's not just us, everyone is trying, but the systems are not made for that, actually. Development systems are not made to be expedited, to be able to pass hundreds of millions of dollars in a short period of time. But at one point, something may give, particularly in Lebanon, where the situation is so complex that the knock-on effects from the Syrian crisis may be felt in a much wider area. So with that, I'd like to stop and open up questions. Please.
Actually, I have a question about the management of Zaatari Camp, or Zaatari Town, as you mentioned. Is there any report or information about conflicts between refugees and the manager or among themselves, and how do they manage it?
Yeah.
Because I heard something in the YouTube, and I was thinking about that during this time. We know the refugees are traumatized, maybe they are depressed, maybe they are nervous, maybe they are angry. But if you label them as a prejudgment, they will come as the angry people. It means if they have a correct objection, you will just manage them by your paradigm since they are angry. I'm just not agree with this type of talking about them, and I want to know how they manage this kind of issue there.
Yep. Do you want people to take a mic? Is that Yeah. Okay. For the next question, we'll take the mic. The answer is yes, there's been a lot of conflict. One of the problems is this camp was built out of scratch from the desert, and in fact, this often happens, but we didn't take into account, we worked much more on the hardware and not the software component, and only after we had a lot of conflict with the management, not just the management, but I mean, you've got the Free Syrian Army in there, you've got a lot of major complicated issues, and there are security problems. So belatedly, there, with the Jordanian government, with the refugees, and with UNHCR, we've worked on a community, both a security, but a community plan of how to work. And we've, again, belatedly, because the camp was rife with criminality, with other areas. So we have started now to set up by block, which should have been done much earlier, to get the community much more involved. It is still a major issue, and again, it's not always the certain political groups within Syria are very strong in those camps, and so there are political issues that go well beyond us. But it also has to deal with the Jordanian government and how much, or any government, and how much they want to get involved in providing the security in those areas and ensuring that it's a safe environment. So, the answer is yes. There's now I'm having a blank of the name, but there's a plan that deals with community mobilization, security with the Jordanian government. But it's and apparently, I mean, the German fellow there named Killian, as I said, I've been to the camp and I have seen a difference, but it's going to take a long time because at the beginning that wasn't done. Other questions, comments? And please introduce yourself as well.
This is Samira. I had a question regarding the healthcare financing. You talked a little bit about using innovative methods. You tried this in Lebanon. If you could talk a little bit more about this, especially, I'm thinking about the non-camp refugees, the situation they're in where they, in some countries like Jordan, they can't work because they're not given work permits. We're trying cash assistance, but a lot of the funding is going towards tertiary care, but then we're also having to respond to those basic health needs of ensuring women have access to safe, deliveries and things like that. So can you talk a little bit more about some of these innovative healthcare financing strategies?
Sure. One of them, I mean, again, we're looking at health insurance for refugees in Jordan. In Lebanon, it's not possible because it's just too expensive. We are looking at cash-based initiatives, as we said. I mean, we're already giving to, I think it's 50,000 vulnerable families in Jordan. Again, it's not enough, but there's a criteria for who is vulnerable, and they get a certain amount of cash through. Jordan is quite advanced, so they have iris scans on their ATM machines. So we're using that, which is very good because it reduces fraud. We've also tried. So we have to divide, I think, because Jordan and Iraq have Iraq in the Erbil northern area have a pretty good functioning healthcare system, and in theory, for the primary care and secondary care, refugees have access. In Lebanon, that's not the case. They have access in some areas, but for the most part, they have only private care. So it's very complex of how to deal with that. There, we have tried, and it's changing constantly, but we have made rules in Lebanon that we went back, I think at one point it was 75, now it's 85% we will cover for secondary or tertiary care up to a point, and then those that are vulnerable have to they have to show that they're vulnerable, and then we can cover 100%, and we're ensuring C-sections and other emergency obstetrical care over the more expensive cancers and other areas. That's for the moment, at least. And then, as I said, in Lebanon, and we may want to put it into Jordan, we found out about this company and it took us a while, but we now have the agreement, and they've started, where anyone that is hospitalized in Lebanon, we will pay this company $50, and they will take care of everything to reduce the costs, and we will see how that goes. That's about the limit of what we have thought of at this point. There are the other big area that within UNHCR and the humanitarian community is cash-based initiatives. And so we've just developed a unit within UNHCR. World Food Program is doing big across the world now with vouchers. This is a way to allow, and this is a way to allow the refugees decision-making and dignity, of course, but of what they want to use this for. But there will always be limits, I would say, particularly for expensive tertiary care, of what can be done and what cannot be done in that provision.
Syrian refugees everywhere. I spoke to some of them, and I spoke to the locals as well. I sort of felt that most Lebanese were not happy because of the I would say the demographic change of the population in Lebanon. So my question is, how much the UN
trying to advocate for those refugees in the sense of making them less of a burden on the population of Lebanon.
No, it's a great. When are you going to come to Hopkins and join?
I'm applying for MPH for next year, so.
Okay, very good, very good. Thanks for crashing. It's really the latter 2 points of what, it's not just UNHCR because we're a humanitarian organization, but the donors and others. It's the idea of Lebanon is extreme, and I don't know if there's been a situation like this before where if you look at the registered and unregistered, and then the Lebanese who are the Syrians who are economic migrants before, who can no longer go back, you have a population, I think Lebanon's about 4.2 or something million, and on top of that, you've got nearly over a million now, so you've got a quarter of this country are Syrian refugees who are able to actually work there. For the most part, they're able to work. So the effects on the national issues are huge, and the Syrians are very worried. I mean, you've just seen the last few days there have been outside the Iranian embassy there was a bombing. So the powers, the broad powers, the big powers are very concerned about Lebanon going back into a civil war, which is why they are trying to work with the bank, in Lebanon there are issues with Hezbollah, so how the U.S. can interact, but ECHO and some of the others, EU. So they're making a big push to actually get developmental funds into those countries to try to ease some of the issues. The problem is that cannot deal, of course, with the ethnic balance, because the majority of the Syrians are Sunni that have come into this area, number one. And then number two is Lebanon, as we said, it's a caretaker government that has a lot of problems making decisions. It's a bit like Congress here. It has a lot of problems making decisions because you need to get every group involved, and one decision has to affect, and if you do this, you have to negotiate for something else. And so actually, even when they're now talking about a huge multi-donor trust fund in order to try to deal with this, to make sure that money can come in, and that will go not just, because this is, at this point, it's beyond, as I said, in Lebanon in particular, but in area, it's beyond a refugee crisis. It's a crisis that is affecting the host populations as much, and therefore it is this linking of development. It's also big issues of reconciliation and other areas within Lebanon amongst the groups, and it's going to be very difficult. I'm a little bit pessimistic, not about Lebanon, because I've heard also very positive things that not a lot of money is flowing into Lebanon to actually start another big civil war, apparently, because things have been going so well that the country apparently doesn't want that. And so I'm hoping that will be the case. But to be able to work in Lebanon and get this huge amount of development money to the country in a time, given the government in an area that will really make a big difference, is going to be a huge challenge. Please.
So in a situation, all three countries, Lebanon, Turkey, and Jordan, neither ICRC or MSF has come in and set up any primary healthcare centers or surgical centers?
Yeah. I mean, both ICRC and particularly MSF in Syria proper, and then we have Adam somewhere. See here, yeah, it was just in Syria with MSF. So they have set up a lot of centers, particularly surgical areas. The problem, though, is that it's so huge. And if you look at the Lebanon, the camps are easy, so I don't think we have to worry too much. They're the access. But the rest of the country, when you look at Jordan, where the refugees are, setting up parallel systems, except for some of the key surgical issues, clearly, and maybe some of the broad public health issues, but setting up parallel services for primary and secondary care probably it's just going to be a bit of a drop in the bucket. And what we really need to do, and we've been trying, is to look at the existing services that the governments have. Lebanon, as I said, it's privatized, so it's more difficult. But in the other areas, looking at the existing and try to improve those areas. So we, and I don't mean just UNHCR, but the humanitarian community has dramatically increased the number of healthcare the healthcare workers and the teachers to be able to, because education is also a major issue in these countries. So now the teachers, they're doing double and even triple shifts But if you can imagine, the host communities who have kids in these schools are not very happy because clearly the education as well as the health care that they received previously are not functioning very well. But bottom line is ICRC, and MSF in particular, are doing a lot, particularly within Syria, primarily in the opposition areas. And they're doing great work, but it's still a drop in the bucket relatively to what's happening in this crisis. Please.
Hi, my name is Phil. I was wondering if you could comment on the role of Syrian community-based groups, either working with UNHCR in the broader humanitarian context, in the role of cross-border and cross-line operations, and sort of remote management, maybe.
Yeah, and actually, you made me think of one other thing. Let me mention that, and then I'll what you said. The other relative, we did what was called UNHCR together with two umbrella NGO organizations did a real-time evaluation, and it's online for you to see. But one of the other areas that's perhaps relatively new is there is a lot of money coming in from the Gulf states, Saudi Arabia and others, but it's not coming through, which is fine, it's not coming through traditional channels. And many of them are through Islamic organizations that don't necessarily wish to work with the UN. And so you have a tremendous amount of money, community-based, both within Jordan, Lebanon, within Syria. But how do we, as the international organization that has systems in place, try to dovetail with all of that money coming in? In some situations, we're able to do it through local municipalities. We are doing that in Lebanon and in certain municipalities. But that's also been a huge challenge because many of these Islamic charities don't have systems in place, and they're very comfortable. They want to give one-offs directly, or they want to work with the families directly. And it would be perfect for them to deal with some of the more expensive tertiary care that we cannot deal with. But this communication and how to deal with that when you have groups that don't necessarily trust each other or have the auditing systems in place to deal with is very complicated. The cross-border, we are not working we are working indirectly, let's say, with many of the NGOs, but it's very positive. I mean, the other thing I've learned over time is that every organization has their mandate, and we should use it to the advantage. So ICRC will do a lot of things behind the scenes. They may not speak out. MSF will speak out. UN is not going to be doing major cross-border operations at this point, but the NGOs are, and we should be able to help them and support them in order to do that. In Syria, the strongest organization by far is the Syrian Arab Red Crescent, the SARC. And there are questions about the politics of it, but they have been the ones that have been able to actually still have access in many areas and deliver. But the Syrian government the current government is still quite strong, and it knows what is going on in the area. And UNHCR in particular, I've forgotten the number, you'll forgive me, it's changing, but we have a tremendous amount of Iraqi refugees that are still there. And we have to be, you always have to weigh how can you help the most amount of people in order to make sure that that your initial action of wanting to do something cross-border won't have a knock-on effect that will cause more problems. Please.
Hi, my name is Yahya. I'm a preventive medicine resident. I was really interested in how virtual communities augment the humanitarian response. And this was particularly after Haiti, when there was a large amount of crowdsourced information, which then fed back, which was processed and then fed back into people on the ground. I'm wondering, do you see that happening in this particular crisis? And going forward, is there a formalized relationship that would form between structures like UNHCR, other international organizations, and virtual communities?
Yeah, no, that it is changed so much. Do you remember in even just many years ago in the Iraqi refugee crisis, it was the Iraqi, so not refugee, but the Iraqi crisis, how many people were killed, and there were all these studies trying to figure it out. Here now, with all the social media that's going on, and as you're aware, there's a group in the UK, there's less controversy about how many people are dying here, meaning we have a pretty good idea. The refugees are, I don't know if this is where you're getting at, but it's not entirely crowdsourcing, but the refugees have contact. What they're doing is they're leaving at times some of their family members in Syria, And there's an area in Zaatari where you go up to that is a better satellite connection, and then they're connecting with people in Syria. So everyone knows, which is quite interesting, not everyone, but many people know what's going on, both at home, what's happening with their houses there. The interconnectivity has been quite fascinating. Similarly, there are I know this is not crowdsourcing, but there's satellite, even in Zaatari, in their most remote area, I don't know how, everyone has satellite dishes, and they're all watching their own, shows that they're very, very well informed. There's a question about how that affects mental health, which would be interesting to know. But it isn't, I know Haiti, they were able to do a lot of interesting things and follow people with their cell phones to know where they were displaced. Here, the networks, for the most part, are working and communication is there. But I was telling our colleagues, some of the other folks here, is that UNHCR is looking at changing their NFIs, their non-food items, and one of the areas is actually having cheap cell phones in stock, and that you give those out to refugees. For the most part, we're finding, especially in middle-income countries, refugees have access to their phone, a phone. They have access to topping up and getting a card, and that we can help them with that. But they're prioritizing that. I mean, one of the most interesting things is to look at what do refugees prioritize with limited amounts of income. Even if you're not giving them cash, they'll sell what you give them to prioritize. And cell phone and cell coverage and SIM cards are one of their highest priorities. Please.
And I'm from Lebanon. So concerning Palestinian refugee camps, because in the past 2 years we've seen a lot of Syrian refugees going to Palestinian refugee camps. And the reason for that, they benefit from the already established primary healthcare system in these camps. But the problem is with the access, because the UNRWA mainly sponsor the Palestinian refugees. So how can we benefit from already this established program?
Yeah, no, that's a great and complicated question. So, of course, the UN we have UNHCR dealing with refugees, and we have UNRWA dealing with the Palestinian refugees. But even that's the Palestinian refugees within certain areas, and UNHCR will deal with Palestinian refugees in other areas, so it's a bit complex. We looked at trying, so it is true, and is that the UNRWA camps, the camps that exist in Lebanon, many Syrians are going in there and actually using the various services. At one point, we tried to look at how, because UNRWA has a lot of very good contracts with various hospitals with very special rates. So we actually tried to be able to look into that, but it wasn't possible for various reasons. It's a good question, and we're trying to work on that. The nice thing is with this RRP 6, this Refugee Response Plan 6, there is space for UNRWA to be able to actually ask for funds as well. But since I have you, what is your perception of, number one, some of the things that I was saying about Lebanon, about the privatized care, but also the perception of the the Lebanese with the amount of Syrian refugees that are in your country?
Okay, so concerning the first question, which is the healthcare, it's a really complicated system. As you mentioned, it's all private, and recently some hospitals started, because we have something called either the private insurance or the NSSF. So within the NSSF, some hospitals stopped taking patients, even Lebanese, who has this type of insurance. So this makes the issue more complicated for refugees, because they don't have an identity of Lebanese identity. So they're not covered by the governmental insurance. And concerning the perception, actually it depends on the religion. I'm really sorry to say that, but that's the fact.
You're right.
Because it's really religious based in Lebanon. So you can see, for example, Shia Syrians or Sunni Syrians or even Christian Syrians heading to areas which have clusters of the same religion, because that's where they feel more secure. And that's where they get more help and more access to care.
Yep.
So it depends on the region.
Yep. Lebanon is one of the most complicated countries that I visited. I mean, Somalia and Lebanon, I'm trying to understand the whole ethnic clan system. I'm still not there. I'm going on Tuesday. At the back, and then we'll come to you.
In work while they're there, and if that has any potential to generate income to help sustain the camps.
Yeah. No, great question. So we have a whole group working on livelihoods in this area. And we have, in fact, our first livelihood strategy coming out in January that deals with this. But the issue so you have the informal and then the formal right to work. So I don't know if things are changing in Lebanon, but for the most part, in Lebanon, the Syrians are allowed to work. In Erbil, or in Irbid area in northern Iraq, most of the Syrians that are coming are Kurdish, and they're allowed to work. In Jordan, they're not allowed to work at all, and so because of the understandable, there's a huge amount of unemployment. So there's a lot of unofficial unemployment, which brings its own problems. So part of the UNHCR's job is to work with the government and others to try to encourage governments to allow refugees to work. In many countries, refugees are, we have a new policy now over the last few years is we do not want camps, and we will only have a camp if the government insists. And generally that's for security reasons or other reasons. And we have some situations in refugees where the government doesn't allow them even to have plots of land outside of the camps to cultivate. So we try to negotiate with the governments, but the governments aren't obligated to do that. In Jordan, it's very, very hard. So we're working. This is where cash comes in. These cash-based initiatives, not to be able to allow them to work, but actually just to be able to allow them to survive. So we have a very policy on that. We actually have different models, the graduation model and others that we're working on with certain refugee groups. But it's quite complex and ultimately depends on the host government who will allow these refugees to work either openly or underground. Thank you.